एउटा PDF देखाउँछु मसँग अरु धेरै केस छ तर एउटा केस मात्र म तपाईलाई अहिले एउटा एक्सप्लेन गर्छु यो केस बारे हामी अहिले डिस्कस छलफल गर्दैनौ यो केस चाहिँ प्लिज पुट इन योर ब्याक अफ योर माइन्ड हैन व्हेन यु आर लुकिङ एट माई स्लाइड्स हैन अनि त्यसलाई कोरिलेट गर्न खोज्नु होला अनि जब स्लाइडहरु सकिसकेपछि फेरि एकचोटी त्यो बारे छलफलको क्रममा आउला यी कुराहरु है यो चाहिँ मैले जापानमा हुँदाखेरि देखेको कुरा हैन एज अ रिसर्चर एज अ क्लिनिशियन पनि अनि अब एनोनिमिटीको लागि नाम चाहिँ हामीले चेन्ज गरेका छौं हैन जसमा सर पढ्छु अहिले मिस्टर राम थापा 25 years was a student at a vocational school in Tokyo. He had been living in Japan for 3 years. One day he noticed some small swelling in his neck. सानो गिर्खाहरु आएको थियो. He also had fever during night time. First he ignored and thought that they will disappear by themselves. However, the swelling increased gradually. बिस्तारै बढ्दै गयो सानो गिर्खा थियो अनि उ चाहिँ क्लिनिकको लागि चेकअपमा गयो. So he visited a nearby clinic for the checkup. Even if he had studied Japanese language for 2 years, he found difficulty to communicate with the doctor in Japanese language. Japanमा चाहिँ डक्टर सबै Japanese language मा बोल्नुहुन्छ. He couldn't understand properly what the doctor was advising him. The only thing he understood is that the swelling may be cancer. He left the clinic being terrified. He thought that he had got cancer. He called his family back in Nepal. They advised him to immediately return to Nepal. He became really scared about his future. I got a call from him. After carefully listening to his history of symptoms, I suspected that he might be suffering from extrapulmonary tuberculosis. Tuberculosis विभिन्न प्रकारको हुन्छ यो extrapulmonary भनेको चाहिँ फोक्सोको भन्दा पनि यो गिर्खा अरु विभिन्न छालाको पनि हुन सक्छ किडनीको पनि हुन सक्छ tuberculosis which affects other organs than lungs, affecting the lymph nodes in his neck. In rare cases, they also might be symptoms of cancer. Rare cases. Cancer को symptom हुन सक्छ गिर्खा सुन्निनु है लिम्फोमाहरु भन्ने एउटा क्यान्सर हुन सक्छ. I tried to arrange his visit with a Japanese doctor specialized in tuberculosis. I also tried to convince him that he can get proper treatment in Japan. However, he was very terrified and returned to Nepal. In a hospital in Nepal, he was treated for extrapulmonary tuberculosis. एउटा सानो केस स्टोरी जुन चाहिँ सत्य घटना मैले भोगेको यो चाहिँ अहिले जस्ट प्लिज पुट इन योर ब्याक अफ योर माइन्ड हैन त्यसपछि जब म प्रेजेन्टेसन गर्छु त्यसमा पनि कुनै कुराहरु कोरिलेट हुन सक्छन् अनि हामी पछि फेरि डिस्कस गर्छौं है त अनि म चाहिँ अब स्लाइड्सतिर लाग्छु सो आजको प्रेजेन्टेसनको टपिक Nepalese migrants in Japan, what is holding them back in getting access to healthcare. Let's start with the background. There are two pictures. यो दुईटा पिक्चर हामी नेपाली दाजुभाइ बहिनीहरु नै हुनुहुन्छ एउटा पिक्चरमा तपाईले एकजना दुईजना रेस्टुरेन्टमा काम गर्ने दुईजना देख्नुभयो अनि अर्को पिक्चरमा चाहिँ विद्यार्थीहरु हो यिनीहरु जापानिज भाषा विद्यार्थीहरु तर त्यहाँ चाहिँ पार्ट टाइम जब गर्दाको यो हुन्छ नि उहाँहरुको यो लुगा लाएर त्यहाँको वर्किङ लुगा यो दुईटा पिक्चर राख्नुको कारण चाहिँ जापानमा सबभन्दा बढी नेपालीहरु इन्भल्भ हुने भनेको एउटा चाहिँ एज अ कुक इन इन्डो नेपाली रेस्टुरेन्ट्स another is Japanese language institutes अथवा vocational schools मा पढ्ने विद्यार्थीहरु जो चाहिँ पार्ट टाइम वर्क गरेर आफ्नो निर्वाह गर्नुहुन्छ है अब ग्लोबली माइग्रेसन कुरा गर्दा माइग्रेसन इज अ युनिभर्सल फेनोमेना एभ्रीवन नोज है ओभर द लास्ट 30 years there has been rapid growth in the migration mainly due to conflict related displacement industrialization unemployment and basically globalization हैन अनि currently there are around 244 million international migrants residing in the world, out of which 75 million are in Asia. Migrants are one of the most deprived and vulnerable groups in the society who receive very least health care. Talking about access to health care, whenever we talk about health, we have to always associate health with the human rights, right? So हामी इक्विटी हेल्थ इक्विटीको कुरा गर्छौं हेल्थ एन्ड ह्युमन राइट्सको कुरा गर्छौं तर माइग्रेन्टको केसमा चाहिँ हेल्थ इक्विटीको सम्बन्धमा ग्लोबली नै लिटरेचरमा हेर्ने हो भने माइग्रेन्ट्सको एक्सेस टु हेल्थ केयर हेल्थसँग एक्सेस चाहिँ राम्रो छैन है अब डेफिनेसनको कुरा गर्दा एक्सेस टु हेल्थ केयर हाउ यु डिफाइन द एक्सेस टु हेल्थ केयर इट क्यान बी डिफाइन एज टाइमली युज अफ पर्सनल हेल्थ सर्भिसेस टु अचिभ द बेस्ट पोसिबल हेल्थ आउटकम्स अनि compared to the general population in the host country, compared to the host population, migrants usually have worse health outcomes, worse health access in the host country. Such kind of poor access to healthcare causes difficulty for migrants to adapt to their host societies. Most of these studies in access to healthcare are conducted in Western world, that means Europe and North America. In case of Asia, despite having 75 million migrants, access to healthcare among migrants is an understudied area. So while I was doing the study on access to healthcare, so I came across with this very analytical model, a framework. We call it Andersen's model of access to healthcare. So in my study, I tried to identify the factors which are impeding the access to healthcare for migrants according to this model. So यो मोडलमा हामीसँग धेरै कुराहरू छन्, तर यो मोडलको the good thing about this model is it analyzes the access to healthcare in both potential, in the domains of potential and realized access. Potential access भनेको perceived access, or तिमी बिरामी migrant बिरामी भएको छैन तर how we perceive he has access to healthcare in that particular situation or not, हैन. अर्को realized access भनेको चाहिँ हेभी उ हस्पिटल गएको छ कि छैन, उ गइरहेको छ कि छैन, उ त बिरामी हुँदा गएको छ कि छैन, realized access. सो यो दुईटा डोमेनमा चाहिँ एनालिसिस मोडलले एनालाइज गर्छ. यो होल फिगरमा चाहिँ मैले बेसिकली यो मिडल पार्ट, द पपुलेसन क्यारेक्टरिस्टिक्स, बेसिकली दे आर इन्डिभिजुअल एन्ड कन्टेक्चुअल डिटर्मिनेन्ट्स अफ एक्सेस टु हेल्थकेयर, त्यो पार्टलाई बढी फोकस गरेँ. सो लेट मी टर्न टु दिस स्लाइड. So in my study, I generally primarily focus in individual and contextual determinants of access to healthcare. So there are three categories according to the Andersen's model of healthcare access: predisposing factors, enabling factors, and need factors. So my whole study revolves around these three factors. Predisposing factor भन्नाले age, sex, ethnicity, education, occupation, individual factors, right? Those are predisposing factors. Second, enabling factors भन्नाले those factors which enable the individual to get the access, to get the health service. For example, health insurance छ भने उसले access राम्रो हुने भयो, employment status, income status, also in language proficiency in other countries, हैन. अर्को lastly third contextual or individual factor is need factor. Is there a need for health checkup or not भन्ने कुरा. पहिलो need पनि दुई प्रकारको हुन सक्छ, एउटा सब्जेक्टिभ र अर्को अब्जेक्टिभ. सब्जेक्टिभ मानो सेल्फ रेटेड हेल्थ स्टेटस, आफैले आफ्नो हेल्थ स्टेटस कस्तो लाग्छ त उसलाई, सब्जेक्टिभ. अर्को अब्जेक्टिभ, क्लिनिकली इभ्यालुएटेड हेल्थ स्टेटस, है. यो तीनटा क्याटेगोरीमा चाहिँ मेरो रिसर्च रिभल्भ हुन्छ, है. Talking about the migrants in Asia, मैले पहिला पनि भने migrants health is an understudied area. There are certain studies, a few studies have been done in migrant health, in the area of migrant health in Asia. For example, just giving some examples, like there was a study done in Central Asian migrants in Kazakhstan, where the researchers found that there was low utilization of health services and poor self-reported health status among migrants. Another study done among male labor migrants in the Gulf country, UAE, they found that there was a high prevalence of depression and suicidal thoughts among labor migrants, right? There are maybe some other few studies, but if you compare to the Western world, Asia, in migrants' health is a very understudied topic, despite having 75 million migrants, right? So now talking about Japan, compared to other OECD countries, Japan has less migrants, right? We have in Japan around 2 million migrants, mostly from China, Korea, Brazil, Philippines, Peru, then comes Vietnam, Nepal, and other countries, right? Japan, one of the problems in Japan is Japan's immigration policy focuses over migrant control over migrants' rights. That has very negative consequences among access to healthcare among migrants. Maybe तपाईहरुले सुन्नुभयो होला universal health coverage को कुराहरु अहिले just I was talking with you for a few minutes back, universal health coverage seminar पनि भयो रहेछ. Japan is a global leader in universal health coverage. Japan is like is an example of universal health coverage. But the problem is that universal health coverage is also only the Japanese population had ease of access, but the migrants, they are still having a lot of barriers in access to healthcare. So it's kind of irony for Japan. Japan is one of the global example of universal health coverage, and universal health coverage says health for all, no one left behind, but migrants are still being left behind, right? Study को कुरा गर्दा जापानमा पनि very less studies are done. Research if you talk about research in migrant health in Japan, there are only few studies done. Some example I would like to show. One study among migrants showed that there was higher incidence of tuberculosis in Japan. And there was another study by Miyazaki. They found that among 38% of Japanese Brazilians living in Japan, they had anxiety disorders. Japanese Brazilians, भन्दा अलिकति confusion हुन सक्छ. Japanese Brazilians भनेको they are the Brazilians of Japanese descent. भनेको चाहिँ when there was like maybe 1950s 60s तिर Japaneseहरु Brazilतिर migrate भएको थियो हैन अनि they were like mixed population, and after 1990 there was a policy change in Japan and they invited all those Brazilians with Japanese descendants and they provide this long-term visa. There are so many Japanese Brazilians, we call it Nikkei in Japanese term and in Japan, and they are very vulnerable, I mean in terms of health, education and so many facilities. Now let's talk about Nepalese migrants in Japan. Hey, currently we have around 85,000 Nepalese in Japan. Japan is being increasingly popular as a destination for Nepalese migrants, and during last 7 years there has been increased by 3-folds of Nepalese population. Nepalese are the number one South Asian population community in Japan. Total अरु सबै country को गर्ने हो भने Nepalese population ranks in number 6. Hey? So from such a small country in terms of, because Japan आफैमा त्यति धेरै migrants छैन तर त्यो मा चाहिँ number 6 मा पर्नुहुन्छ. र एउटा interesting fact, Japan is only the country except Nepal where Nepalese are more than Indians. Right? Indians are everywhere. Japan is the only country where, except Nepal, Nepalese are more than Indians. But Nepalese are the biggest South Asian community in Japan. Now, most of the Nepalese migrants, they are the big population is of language students. भाषा विद्यार्थीहरुको रूपमा आउनुहुन्छ र भाषा विद्यार्थी प्लस भोकेसनल स्कुल भाषा विद्यालय सकेपछि 2 वर्षको भाषा विद्यालय सकेपछि यो भोकेसनल स्कुलमा जोइन गर्नुहुन्छ. अर्को पपुलेसन भनेको कुक्स इन इन्डो नेपाली रेस्टुरेन्ट्स. तपाई जापानको विभिन्न जुनसुकै अहिलेको अलमोस्ट देयर आर 47 प्रिफेक्चर्स इन जापान. अनि प्रत्येक प्रिफेक्चरमा प्रत्येक जसो प्रिफेक्चरमा यु क्यान फाइन्ड इन्डो नेपाली रेस्टुरेन्ट्स. है, इन्डो नेपाली रेस्टुरेन्ट्स रन बाइ नेपाली पिपल, नेपाली ओनर एन्ड नेपाली कुक्स. है, अनि अर्को पपुलेसन भनेको डिपेन्डेन्स अफ दोज कुक्स भनेको वाइफ्स चिल्ड्रेनहरु अफ दोज कुक्स इज अनदर बिग पपुलेसन इन जापान. अनि यसमा पनि जुन भाषा विद्यार्थीहरुको अघि हल्का देवेन्द्रजीसँग पनि कुरा भइरहेको थियो, जुन भाषा विद्यार्थी भएर भनेर आउनुहुन्छ, दिस बिग पपुलेसन Nepalese migrants. They seem like they are educational migrants, but basically they are economic migrants. In book they are educational migrants, but in reality they are economic migrants. भनेको पढाइ भन्दा पनि कमाउनका लागि जाने यो उद्देश्य चाहिँ हैन बढी छ. त्यसले गर्दा अब त्यहाँ जस्तो विद्यार्थीले हप्तामा 28 घण्टा काम गर्न पाउँछ है जनरली. तर I will say more than 90% of the students, not only Nepalese, or the Vietnamese, Indonesian, Chinese, they work more than 50 hours per day, for 50 hours per week. Right? It's Japan ko context is illegal. तर पनि मैले भनेको चाहिँ they are in book they are educational migrants, but in reality they are economic migrants. Right? And in terms of research, little is known about their access to healthcare of all those Nepalese migrants. Right? Now, talking about the justification of my study, as I already mentioned, Asia there is very less study among migrants, and most of the studies are in Western world. And this the differences in socio-cultural environment between Asia and Western world may reveal different dynamics of factors associated with access to healthcare. So that is one justification of conducting this research. Another is most of the studies done in Western world also among migrants in terms of access to healthcare, they have analyzed several factors, but they have analyzed in individual way. There is no such combination analysis. So in my study, what I did is I did some kind of combination analysis. So associations with access to healthcare among the migrants when such factors are combined is globally not known. Such kind of combination analysis may reveal the factors which can play a more important role compared to others. So kun factor is a body role play गर्छ भन्ने निष्कर्ष निकाल्नको लागि त्यो combination analysis help गर्छ. Therefore, the objectives of my research was to examine the factors associated with access to healthcare among Nepalese migrants in Japan based on Andersen's model. That is number one objective. Number two objective was to examine the association of those factors with their access to healthcare when several key factors are combined. Now, going to the method section, यो picture saying the every year Nepal festival हुन्छ टोकियोमा है, अरु प्रिफेक्चरमा पनि हुन्छ, टोकियोमा चाहिँ every year हुन्छ. त्यो यो चाहिँ मैले 2013 मा लिएको पिक्चर है. So now talking about the study area and study design. This study was a cross-sectional study, and for study area we conducted this study in 10 prefectures of Japan. So in Japan generally 47 वटा prefectures छ, त्यसमध्ये 10 वटा prefectures मा हामीले स्टडी गर्यौं. त्यो study prefectures how we selected is number of Nepalese population कहाँ बढी छ त भने चाहिँ टप 10 हाईएस्ट एरियामा गर्यौं. सबभन्दा बढी Nepalese population भनेको टोकियोमा छ, जुन क्यापिटल है. टोकियो पछि फुकुओका भनेको चाहिँ साउथतिर, अलि साउथतिर तलतिर, अनि टोकियो, फुकुओका, ओसाका, गुन्मा, तोचिकी, ह्योगो, खानागावा, चिबा, आइची र साइतामा, यो 10 वटा प्रिफेक्चरमा चाहिँ हामीले स्टडी एरिया फिक्स गर्यौं. Sampling अनि स्टडी यो to recruit the migrants, so we used a convenience sampling method. Because migrants are a hard to reach population, they are not general population. Migrants are hard to reach population, so we thought convenience sampling would be more feasible, and we did convenience sampling method in each study prefecture. So to recruit the migrants, first we identify the key informants in each prefecture. Key informants meaning we found out local community leaders in Nepalese community in each prefecture, and we contacted them, and through their contacts we could identify Nepalese studying in language schools, professional training schools, and we visited those schools, colleges, restaurants, and other work areas where we can meet Nepalese migrants to recruit our participants. So the criteria of recruiting the participants was is in the slide. So the inclusion criteria of the participants was being a Nepalese citizen, both either male or female, is 18 to 60 years, residing in the study prefecture among the 10 study prefectures in one of the study prefectures, and those who have stayed continuously or with interruption for at least 3 months in Japan, and who is willing to participate voluntarily in this study. One exclusion criteria we make was we exclude those participants who cannot read and write in Nepali language. Now talking about sample size, calculation of sample size was done using G-Power software, and we use a study from a previous study conducted among international students in Japan as a assumption to calculate the sample size. And our sample size calculation gave us 456 migrants, the minimum sample size. However, we distributed questionnaires to a total of 981 potential participants because of anticipation of the missing data and also non-response to our self-administered questionnaire, because in our questionnaire we also have some sensitive topics like mental health. So just to counteract that, we distributed our questionnaire to potential 981 participants. And it's the outcome variable, what we measure. Outcome variable is access to healthcare. So as I mentioned while talking about Andersen's model, access to healthcare we measure by 2 binary variables for each potential access and realized access. To measure potential access, we ask questions like if the migrants currently have proper access to doctor or health worker or not. That is for perceived access or potential access. For realized access, we ask them if in the past year they needed to see a doctor health worker for an illness condition but did not. Even if they were sick, they didn't attend the hospital. So it's more like unrealized access rather than realized access. Right? So this kind of instrument has been previously used among the migrants in Central Asia. For the independent variables, we use certain socio-demographic characteristics like age, gender, occupation, employment, education status, and migration-related characteristics like the length of stay in Japan, their visa status, legal status, employment status, their language skill score, and their perceived social support. Perceived social support was measured through a scale called MSPSS. And for health and behavior-related characteristics, we asked questions about their alcohol use, about their sleep duration, and about the health insurance, do they pay health insurance premium regularly or not, and also their need of Japanese language interpreter while visiting the hospital. Others like common mental health problems and self-rated health status. Data collection. For data collection, we use a self-administered questionnaire in Nepali language. Before our main study, we go for pre-testing for 40 participants, and based on our pre-testing, we do some amendments in our questionnaire and use for main survey. For the main survey, I along with 8 trained Nepalese assistants, we visited 10 prefectures and recruited the migrants. And the data collection was done from April to July 2016. For data analysis, we did two kind of analysis. First was this descriptive statistics for to know the socio-demographic migration-related and health and behavior characteristics. And the main analysis we did was the multivariable logistic regression analysis. So in this regression analysis, we used two statistical models. First statistical model was to examine the factors associated with access to healthcare among the migrants. And in the second statistical model, after we found out the associated factors, we combine those factors and put those combined factors in the second regression model. So I'll be explaining while explaining the results section. So model 2 was to examine the association of factors when key predisposing, enabling, and need factors are combined. And for the data analysis, we use the Stata version software for data analysis. Ethical consideration, ethical approval was obtained from the Research Ethics Committee of the University of Tokyo. All the migrants participated voluntarily, and we also obtained written informed consent. And migrants' identity were kept anonymous by using identification codes only. We don't use their names or other things. We just use ID code to make them anonymous. Now, results section, and this photo is about educational seminar conducted in Tokyo for Nepalese students. Now this flowchart shows how the flow of the questionnaires went. So as I mentioned earlier, we distributed a total of 981 questionnaires to participants. Out of them, 765 questionnaires came back. And out of 765, 26 did not include any written consent, so we excluded them. And a huge number, 97 questionnaires, they have missing data. So it's a problem with self-administered questionnaires, so we have to exclude them. And for analysis, we use in final 642 questionnaires, sample size of 642 migrants. Now talking about the results section, let's see about the socio-demographic characteristics of the migrants. The mean age of the migrants was 28.3 years. More than 70% of the migrants were male. Talking about marital status, 53% of the migrants were unmarried. Now, migration-related characteristics, the mean length of stay in Japan was 3.9 years. Visa status, most of them were student visa status. That is 56.5%, followed by skilled labor or their dependents. Health and behavior-related characteristics. More than 50% of the migrants self-rated their health status as poor or fair. And talking about the health insurance premium payment, around 35% of the migrants said that they had not paid the health insurance premium for a year or more. So they are irregular payers. This is one of the very important variables I will be talking later. Talking about the need of language interpreter, around 70% of the migrants say that they need Japanese language interpreter during visit to health facility. Okay, so this is the more like socio-demographic characteristics. Now talking about the common mental health problems, we also collected data on their depression, anxiety, and stress score. Around 24% of the migrants had scored more than 16. So 16 is the cutoff point in the depressive score. Yes or no? I mean, like if you score more than 16, that means they have depressive symptoms. So around 24% is a huge number. 24% of the migrants had depressive symptoms. And talking about outcome variable, around 70% of the migrants say that they don't have better perceived access to healthcare. Around 70%. And lastly, for their unrealized access, around 31% of the migrants say that they did not visit the health facility in the past year, even if they need to, even if they were sick. Around 32% have that unrealized access. Now, after this, I will explain about the model 1. So this is a regression analysis, multivariable regression analysis. The factors I have shown are only the statistically significant factors I have included in this table because it's a very long table. So I only included the statistically significant variables. These all variables were adjusted by so many factors which I have mentioned in the parenthesis, which are divided into 3 categories, as I mentioned, because it's based on Andersen's model. So 3 categories are predisposing, enabling, and need factors. So just explaining the results, since we have 2 outcome variables. First is the perceived access, that is potential access, and the unrealized access. So as you can see, regarding predisposing factor, length of stay in Japan was significant. That means those migrants who stay for longer years were more likely to have better access to healthcare. You can see our odds ratio is significant, statistically significant. And also talking about enabling factors, those migrants who said they don't need Japanese language interpreter during health facility were more likely to have better access. Okay, and they're also they're less likely not to see a doctor when sick. Negative value we have also issues. And those migrants who were irregular payers, who did not pay the health insurance premium regularly, were less likely to have better access to healthcare. And lastly, those migrants who self-rated the health status as poor or fair were less likely to have better access to healthcare. So from this model 1, we identify these 4 factors in 3 categories which are statistically significantly associated with access to healthcare. So this is model 1. So model 1 gave us primary results. So what we do in model 2 is these positive factors we combined and try to see how this combination affects the access. Okay? So this combination was done based on presence or absence of these factors. Okay, so let me explain in the table. So before we did the multivariation model 2, we just did a bit of prevalence, just descriptive data. So as you can see, so there are 3 factors: predisposing factor, enabling factor, and need factor. So for a predisposing factor, it was length of stay in Japan for more than 4 years. So we take only the positive factors. For enabling factors, it was they not needing a Japanese language interpreter during visit to health facility and regular payment of the health insurance premium. It was enabling factors. For the need factor, it was self-rating the health status as good, very good, or excellent. So all this, we categorize these 4 factors in 3 categories. So presence or absence of these factors, based on that we combine the factors. For example, you can see on the first row, y means presence of that factor, n means absence of that factor. So when all these factors were present, all these 3 factors were present, more than 70% of the migrants had better access to healthcare. Okay, that's the meaning. Let's go to number 2. When only 2 factors are present, only predisposing and enabling factors are present, need factors are absent, around 50% has better access to healthcare. Let's go to the last one, the red one. When none of these factors were present, none of these positive factors were present, only 20% of the migrants had better access to healthcare. So it gives a bit of general view on combination. So it's just a descriptive statistics I show you. But now in the next part, I will show how I did the regression analysis. So it will be more clear in that analysis, and it will be more. So let's go. So this is the regression analysis in model 2. So what we did is we combined, as I said, combination was done based on presence or absence of those 3 factors. Those 3 factors are, as I mentioned, predisposing factor was length of stay more than 4 years. Enabling factors was not needing a language interpreter and paying regular health premium. Number 3, need factor was self-rating health status as good or very good or excellent. So in this model also I have only shown this part. Other adjusting variables I haven't shown because it will be very long. So as you can see, compared to those migrants who don't have any of those factors. So N, the first N shows migrants who they don't have any of those factors. So I haven't included the value. It will be like 1.0. So it's like redundant. I didn't mention. So it is a reference category. So that's a reference category, the first one. So compared to those migrants who don't have any of those factors, migrants who have all those factors, why, they are more likely. They are like almost 10 times more likely to have better access. Okay, so that's the first point. Second point, the migrants who have predisposing and enabling factors but not need factors, they were 4 times more likely to have better access. Third point, migrants who have enabling and need factors but no predisposing factor, they were almost 3.9 times more likely to have better access to healthcare. So one interesting thing you can see in these 3 rows, that enabling factor is common in these 3 rows, 3 findings. So enabling factor is present in all these 3 findings. That means enabling factor has more central and important role. So this is one of the the advantage of doing combination analysis. We can find which factor is more important. So let me make it more clear in this slide. Let's go to discussion section. So this slide, I think it will be more clear. So compared to those who don't have any of those factors, the migrants who had all these factors were more likely to have better access to healthcare compared to those who don't have any of those factors. And also we can see that enabling factor is present in all these three. That means when they have enabling factor combined with any other factors, they are more likely to have better access to healthcare compared to those who don't have. So this gives us a very important conclusion that enabling factors may have more important role than predisposing and need factors. And enabling factors are not needing a Japanese language interpreter during visit to health facility and regular payment of health insurance premium. So language and health insurance, these two stand out. So the good thing about these two is they are modifiable factors. That means while we are making policy, we are doing intervention, these factors can be included, that can be modified. For example, predisposing factor like length of stay, we cannot modify that. But we can modify their need of language interpreter. We can modify the health insurance needs. So enabling factors such as need of language interpreter, health insurance are quite modifiable. Modifiable variables are useful in promoting access to healthcare. And availability of language interpreter reduces the miscommunication between health workers and patients, and also encourages the migrants to utilize health services. Being insured significantly increases the health service utilization and decreases the delay in healthcare. Let me a bit more talk about irregular payment of the health insurance premium. So what happens is in Japan, everyone, either they are migrants or they are citizens, they are mandatory to go under any kind of one public health insurance scheme. So what happens is these migrants, Nepalese migrants, whoever migrants, when they enter the Japan, they enter to this NHI, National Health Insurance Scheme. But what happens is they do enter the National Health Insurance Scheme, they also have this card, everyone has one card. But the problem is they don't pay the health insurance premium regularly. The health insurance premium is determined by in the first year there is a basic health insurance premium. In the second year, the health insurance premium is determined by their last year's salary. Okay, so in our study we found that more than 1/3 of the migrants did not pay the health insurance premium regularly. So that was a very important finding. So failure to pay for many years results in heavy cost of back payment for premium. So if they haven't paid during my course of field work, I found Nepalese migrants, especially those cooks who have not paid the health insurance for 4 years, 5 years, 6 years. So those health insurance premiums, they pile up. So as a back payment. So if they want to go to hospital and want to get treated in a subsidized manner, they have to pay all the back payments. That's why they are reluctant to go to the hospital. That's one mechanism. So especially I remember I was doing full field work in Osaka, and I went to some restaurants there and talked to Nepalese cook, and like they have a lot of most of them have this backache problem because they have to stand a lot of time, and they have never done the X-ray, MRI, whatever. And even they have not ever checked their blood pressure also. I checked their blood pressure, I found hypertension and all those things. So when I asked them, why didn't you go to a hospital? They were saying all this in health insurance, they have not paid and everything. And they said that, okay, Dr. Shah, म अर्को वर्ष चाहिँ नेपाल जाँदैछु, अब 6 वर्षपछि नेपाल जाँदैछु, त्यो बेला चाहिँ अब म चाहिँ आफ्नो नेपालमा सबै होल बडी चेकअप गराउँछु. Let's see the reality. You are staying in a country like Japan where you have the state-of-art health facilities, cutting-edge technology, everything is there. But to do your health checkup, you are going back to Nepal. It's disappointing, right? So it's all because we have poor access to healthcare because of certain factors. Not only the health insurance, as I show you, the enabling factor was very important: language, interpretation, and other factors. And we found we tried to explore the reason behind why they are not paying health insurance. Most of them they were talking about they have like negative perception on costs and benefits of health insurance. Most of them they are not aware about what are the benefits of health insurance. जस्तो कोही दाजुभाइ सोध्यो भने किन नतिर्नु भएको, तिरेर के हुन्छ र यो मैले यो वर्ष तिरे म बिरामी भएन भने त मैले त्यत्रो पैसा खेर गयो नि. We don't have that health insurance culture. किन भन्दाखेरि in Nepal, man, health insurance framework policy was started in 2013. They made a policy framework in 2013, and since 2015 there is the social health security in Kukura Airasa. It has yet to be implemented. So basically, Nepal, out-of-pocket payment is the major source of health financing. Right? So Nepalese migrants who went to Japan, they were never exposed to this health insurance culture. So that maybe that kind of lack of exposure have resulted in this irregular health insurance payment. And another part is language interpretation. as I said, almost all doctors they use Japanese. They don't even only few doctors they know English in Japan. Japanese language is the method of communication with patients. So the problem is, even if most of the students they go to Japan to study as a Japanese language student, their Japanese language ability is not that good. As I said, they are educational migrants in book, but in reality, generally, if you go to the Japanese Language Institute to observe how students are studying, generally in morning class, I used to go, 50% of students are sleeping in the class. Like sleeping in the class is very normal in Japan. के हुन्छ भन्दाखेरि विद्यार्थीहरू चाहिँ अब मैले भने 28 घण्टा भन्दा बढी काम गर्न पाउँदैन तर 28 घण्टा काम गरेर यु विल नेभर सर्भाइभ इन टोकियो लाइक कस्टली प्लेस लाइक टोकियो मन्थली रेन्ट मात्र मिनिमम 50,000 येन हुन्छ हैन सो दे हैव टु डु 28 सो धेरै स्टुडेन्टहरू चाहिँ राति काम गर्नुहुन्छ नाइट ड्युटी गर्नुहुन्छ एनर्जी ड्रिंक खाएर कफी खाएर है त्यो एनर्जी ड्रिंकको पनि लाइक लट अफ हेल्थ प्रब्लम्स आइराछ राति काम गर्नुहुन्छ नि बिहान क्लास जाने भनेको सुत्नको लागि बिहान अनि क्लास गएन भने के हुन्छ एटलिस्ट 90% एटेन्डेन्स हुनुपर्छ 90% एटेन्डेन्स भएन भने चाहिँ अर्को वर्ष भिसा पाउँदैन सो अझ कुरा गर्दै थिएँ नि भनेको द्याट्स द रिजन है अनि ल्याङ्ग्वेज भए तापनि कस्तो हुँदो रहेछ भन्दाखेरि इभन इफ यु हेभ सम बेसिक नलेज अफ जापानिज ल्याङ्ग्वेज वाइल यु टकिङ अबाउट मेडिकल केयर हेल्थ केयर इट्स अ डिफ्रेन्ट बलगेम तपाईँले बेसिक जापानिज बोलचालको जिन्दगी आई मिन ट्रेनमा बोल्ने पसलमा बोल्ने सामान्य बोल्ने जान्दैमा तपाईँले आफ्नो हेल्थको कुरा मेडिकल सिम्टम चाहिँ जापानिजमा भन्न अथवा उसले भनेको तपाईँले बुझ्ने डिफ्रेन्ट बलगेम जस्तो फर इक्जाम्पल हामी नेपालीमा जस्तो कस्तो हुन्छ भन्दा जस्तो नेपालमा हामी जब हस्पिटलमा बिरामीले कसरी सिम्टम भन्छ इट्स भेरी टिपिकल तरिकाले भन्छ डाक्टर साहब मेरो टाउकोदेखि तलसम्म रन्किएर आउँछ गानो जान्छ के अरे झमझमाउँछ खुट्टासम्म यो भनेको यो तरिकाले पेसेन्टले कम्युनिकेट गरेर हुन्छ नेपालमा है अनि त्यही कुरा जापानिज भन्ने त कुरा आउँदै आएन तर पनि त्यही सिमिलर कुरा भन्न पनि गाह्रो नै हुन्छ है त्यही भएर अलिअलि जापानिज जाने पनि डिल गर्न गाह्रो हुन्छ त्यही भएर हामीले चाहिँ आज के भनिरहेको छौँ भन्दाखेरि नट ओन्ली द प्रोफेसनल इन्टरप्रेटर वी निड कल्चरल मिडिएटर्स बिट्विन डक्टर्स एन्ड पेसेन्ट है यसमा अर्को कुरा एउटा जोड्न मन लाग्यो जापानमा देयर इज अ बिग मेन्टल हेल्थ प्रब्लम मेन्टल हेल्थको पार्ट चाहिँ मैले आज एक्सप्लेन गर्न द्याट इज एनदर पार्ट अफ माई थेसिस मेन्टल हेल्थ प्रब्लम चाहिँ कस्तो हुन्छ भन्दाखेरि स्पेसली यो इन्डियन सब कन्टिनेन्टको हामीहरू साउथ एसियामा रहनेहरूको हामीले मेन्टल हेल्थ आफूलाई भएको कुनै डिप्रेसन एन्जाइटीलाई के अरे इन्टरप्रेट अथवा मेनिफेस्ट गर्ने तरिका इज भेरी डिफ्रेन्ट देन वेस्टर्न वर्ल्ड अर जापान जस्तो हामी कहाँ आउने मान्छेहरू मेन्टल हेल्थको पेसेन्टहरूले कसरी सिम्टम भन्नुहुन्छ भन्दाखेरि डाक्टर साहब मेरो टाउको दुखी गर्छ जे गर्दा पनि दुख्छ भेग सिम्टम हुन्छ पुरै शरीर दुख्छ पुरै शरीर झन्झनाउँछ नसाहरू दुख्छ यसरी मेन्टल हेल्थको सिम्टम भन्नुहुन्छ कसैले जस्तो वेस्टर्न वर्ल्ड अथवा अरू ठाउँमा जस्तो म निराश छु यस्तो खालको सिम्टम्सहरू भन्दैन हामी चाहिँ मेडिकल भाषामा सोमाटाइजेसन अफ द मेन्टल हेल्थ सिम्टम भन्छौँ होइन बडीले सिम्टम्सहरू त्यसरी भन्नुहुन्छ अब त्यहीको जापानमा चाहिँ हामीले के देखिरहेको छ भने उहाँहरू बिरामी हुनुहुन्छ हस्पिटलमा जानुहुन्छ जापानिज डक्टरलाई जापानिज भन्नुहुन्छ यस्तो यो पेट दुखेको टाउको दुखेको अनि जापानिज डक्टरले पेट पनि चेक गर्छ सबै चेक गर्छ तँलाई ठिक छ तँलाई के भएको छैन भनेर पठाइन्छ है जापानिज डक्टरले अनि हामीले चाहिँ अनि हामी कोही नेपाली डक्टर हुनुहुन्छ हाम्रो एउटा ग्रुप छ टोकियोमा अथवा ओसाकामा अनि हामीले एउटा सानो हटलाइन जस्तो पनि चलाइरहेको छौँ क्या यो म पछि एक्सप्लेन गर्छु होला अनि उहाँले हामीलाई फोन गर्नुहुन्छ डाक्टर साहब म हस्पिटलमा गएँ पेट दुखे टाउको दुखेको थियो गएर भने त्यहाँ डक्टरले चेक के औषधि पनि दिएन भनेर आत्तिएर हामीले चाहिँ आफ्टर टकिङ फर फ्यु मिनट्स वी अन्डरस्ट्यान्ड दिस इज मोर अबाउट गोइङ टु मेन्टल हेल्थ साइड स्ट्रेस रिलेटेड डिसअर्डर्स सो मेनी पिपल हेभ स्ट्रेस रिलेटेड डिसअर्डर्स इन जापान है त्यसमा एक्सट्रिम कन्डिसन भनेको सुसाइडको केसहरू पनि बढिरहेछ एभ्री इयर 3-4वटा केसेसहरू वी आर फाइन है Okay, so talking about the strength of the study, I think I should. This is a pioneer study conducted on health issue of Nepalese migrants in Japan. So this is one of the study, and this is a study where one of the strength of the study. This is the first study to examine the association of factors with access to healthcare when 3 major key factors are combined. Such a kind of analysis may help the migrants globally to take individual and collective action step by step. Talking about the limitation of this study, there might be bias in representing the population because we use convenience sampling. As I told earlier, migrants are hard to reach population. Methods such as convenience sampling provides the best opportunity to recruit a relevant sample, and in such case, it's not feasible to get representative sample. Another limitation might be the self-reported information, self-reported bias. And last limitation is we did not explore the system and provide other factors. We only explore the individual and contextual determinants. So that is another limitation. So conclusion of our study was, as I already mentioned, central role of key enabling factors for better access to healthcare. Those are language ability and health insurance. So these have the key role. So based on my conclusions, recommendation, we would like to recommend that we need interventions to improve migrants' access to healthcare. Basically, we need to reduce the language barrier. For example, we can recruit cultural mediators or professional language interpreters to decrease this barrier. And also, we need some programs that will encourage the migrants to pay the health insurance premium regularly. And another recommendation is future studies should be done on influence of system and provider level factors too. I would like to acknowledge following person and institutes for helping out in this research. If you want to know the further details about the research, this paper based on this study has been published in a journal called PLOS ONE, so you can find out the details on methods and results and everything. Okay, you can search it. Further details. So before I go to discuss this, I'll just quickly try to say just to research for the sake of research. गर्नु एउटा ठाउँमा छ रिसर्च गर्छौँ पेपर पब्लिस हुन्छ राम्रो जर्नल त जस्तो कि peer review journal always हुन्छ तर it always takes time to go to policy, right? That's what always there is a gap between research and policy. हामी चाहिँ के थियो भन्दा हामी जापानमा हामी एउटा मेडिकल डक्टर्स र हेल्थ प्रोफेसनल्सको ग्रुप थियौँ अनि त्यही भएर हामी रिसर्च गरिरहेको छौँ ठिकै छ तर हामीसँग एउटा रिसोर्स भएको हुनाले why don't we do something for improve the access to healthcare भन्ने तरिकाले हामीले चाहिँ बेला बेलामा जापानमा हेल्थ क्याम्पहरू गऱ्यौँ हेल्थ क्याम्पमा स्पेशली हेल्थ काउन्सिलिङ क्याम्प भनेको त्यहाँ अब नेपालमा जस्तो हेल्थ क्याम्प भनेर औषधि बाँड्ने त्यस्तो गर्न मिल्दैन हेल्थ काउन्सिलिङ सामान्य चेकअप हैन हामीसँग इसिजी मसिन हुन्थ्यो इको मसिन हुन्थ्यो अनि अरू सामान्य क्लिनिकल चेकअपहरू हुन्छ बीपीकोहरू त्यसमा अनि हामी चाहिँ नेपाली डक्टर्सहरू हामी केही नेपाली डक्टर अनि केही जापानिज डक्टरहरूसँग मिलेर देयर इज नट अ सस्टेनेबल वे टु प्रोभाइड हेल्थ एक्सेस डेफिनेटली हैन तर पनि एटलिस्ट केही नहुनु भन्दा केही हुनु नै बेटर भनेर स्पेशली हामीले भल्नरेबल पपुलेसनहरू खोज्यौँ कुक्सहरू अर्को एउटा पपुलेसनको मैले कुरा गरेको छैन 7% जति हाम्रो स्याम्पलको दे आर रिफ्युजी एप्लिकेन्ट्स मोर करेक्टली सेङ फेक रिफ्युजी एप्लिकेन्ट्स भन्छु मैले चाहिँ भन्नुको भिसा एक्सटेन्ड गर्नको लागि फेक रिफ्युजी फाइल गरेर बस्नेहरू हुनुहुन्छ तिनीहरू चाहिँ भेरी भल्नरेबल पपुलेसन है जस्तो यो तोचिकी भन्ने यो प्रिफेक्चरमा गरेको क्याम्पको फोटो हामीले डेन्टल क्याम्पहरू थियो अरू नेपाली जापानिज साथीहरू हुन्थ्यो है अनि वी डिड अल्सो इन टोकियोमा एउटा एभरेज इन्टरनेसनल स्कुल भन्ने एउटा नेपालीहरूको स्कुल छ उनीहरूले हामीलाई भेन्यू प्रोभाइड गर्छ अनि एभ्री इयर हामीले त्यहाँ क्याम्प गर्छौँ अनि यो यु क्यान सी एक्सरे बस पोर्टेबल मोबाइल एक्सरे बस त्यो चाहिँ टोकियो मेट्रोपोलिटन गभर्मेन्टको सहकार्यमा टोकियो मेट्रोपोलिटन गभर्मेन्टले हामीलाई प्रोभाइड गर्छ उनीहरूले एक्सरे टेक्निसियन्सहरू पनि प्रोभाइड गर्छ सहकार्यमा हामीले 2017 देखि रेगुलरली गरिरहेको 17, 18, 19 मा गरिसक्यो हामीले अनि त्यसै गरी हेल्थ अवेरनेस सेमिनारहरू पनि गर्छौँ बेला बेलामा हाम्रो आशा भनेर एउटा हामीसँग एउटा एनपिओ दर्ता गरेका छौँ टोकियोमा त्यसमा चाहिँ नेपाली र जापानिज प्रोफेसनल्सहरू हुनुहुन्छ अनि त्यो संस्थाको अन्तर्गत रहेर हामीले जस्तो यो अब तपाईँको दन्त चिकित्सा सम्बन्धी दाँत कसरी अब प्रोटेक्ट गर्नेदेखि लिएर मुटु सम्बन्धी मुटु रोगको बारेमा हैन अनि यो डक्टर विशालको क्यान्सरको सम्बन्धी यी कुराहरूमा हामीले सचेतना गोष्ठीहरू गर्छौँ अनि त्यसै गरी टोकियो बाहेक अरू थ्याङ्क यू अरू सहरहरू जस्तो फुकुओका भनेको चाहिँ साउथ इन्डमा पर्छ जापानको त्यहाँ चाहिँ धेरै विद्यार्थीहरू हुनुहुन्छ है धेरै नेपाली विद्यार्थीहरू तपाईँ त्यो फुकुओका जानुभयो अथवा त्यहाँ फुकुओकाको हाकाता भन्छ स्टेसन मेन स्टेसन त्यहाँ म पनि असम पहिलोपटक जाँदा यो 2017 मा गएको थिएँ असम परेको थिएँ म भनेको त्यहाँ त्यति धेरै विद्यार्थी होला भने लागेको थिएन त्यहाँ चाहिँ तपाईँको प्रत्येक कन्भेन्सन स्टोरमा एउटा नेपाली विद्यार्थी भेट हुने त्यहाँ कति कन्भेन्सनहरू छ एउटा नेपाली विद्यार्थी भेट हुने त्यति धेरै अनि त्यहाँ चाहिँ हामीले त्यहाँ भन्छ त्यहाँको लोकल फेस्टिभलहरूमा नेपाली फेस्टिभलहरूमा हेल्थ क्याम्पहरू गर्थ्यौँ हामीले अनि त्यो बाहेक अब यो दिस अ फ्लायर सो इट वाज सपोर्टेड बाई एनआरएनए अल्सो दे अल्सो सपोर्ट अस फाइनेन्सियली टु अर्गनाइज एन्ड अर्गनाइज बाई आशा द एनपिओ वी रजिस्टर त्यसै ओसाकामा गरेको यो हेल्थ क्याम्प भयो अनि अदर एक्टिभिटी हेल्थ क्याम्पमा अरू एक्टिभिटी के गरेको थियौँ भने हामीले मेन्टल हेल्थको क्याम्पेन पनि गरिरहेको थियौँ अहिले पनि कन्टिन्यू छ म त्यता आएँ हाम्रो मेन्टल हेल्थको काउन्सिलर हुनुहुन्छ अनि विथ कोलाबोरेसन विथ एनआरएनए वी सबमिटेड रिपोर्ट टु एम्बेसी देयर so that we can intervene in the mental health part, but progress we don't know yet. हामीले त्यो कुराहरुमा एडभोकेसीमा पनि काम गरिरहेको छु भन्नु खोजेको मैले। अनि अर्को एउटा अहिले पनि भने हामीले चाहिँ एउटा जस्तो सोशल मिडियाको थ्रुबाट पनि हेल्प गर्ने हिसाबले जस्तो नेप्लिज हेल्थ इन जापान भन्ने एउटा फेसबुक पेज छ, त्यसमा चाहिँ धेरै जापानमा बस्ने नेपाली विद्यार्थी भाइहरु कुहरु जोडिनु भएको छ। उहाँले के समस्या पर्यो नि हामीलाई फोन गर्नुहुन्छ, मेसेज गर्नुहुन्छ, हामीले चाहिँ कुन हस्पिटल जाँदा ठिक हुन्छ, कुन हस्पिटलमा चाहिँ नेपाली इन्टरप्रेटर पाइन सक्छ अथवा कुन हस्पिटलमा एटलिस्ट इङ्ग्लिस इन्टरप्रेटर भने इङ्ग्लिस बुझ्नेहरूले भने त्यस्तो खालको सल्लाह दिन्छु। अनि कुनै कुनैलाई जस्तो मैले भने नि स्ट्रेस रिलेटेड डिसअर्डर हुन्छ, डक्टरले के औषधि दिएन भन्ने हुन्छ, त्यस्तोहरूलाई काउन्सिलिङ गर्ने, सामान्य काउन्सिलिङ गर्नेदेखि लिएर त्यस्तो कुराहरू चाहिँ हामीले गरिरहेछौँ। सोसल एडभोकेसी प्लस इन्टरभेन्सन पनि भयो है। अनि some pictures of our activities in Nepalese and Japanese newspapers है। यो चाहिँ मैले स्किप गरेँ, हाम्रो टाइम पनि भक्यो है है त, थ्याङ्क यू।